So the way that we kind of came to some of the, say, the clinical outcome measures, or primarily the neuropsychological outcome measures, really has evolved over 40 some years from some giants in our field who started to, figure out ways to test learning and memory in people with Down syndrome who have a pre-existing intellectual disability. That means we can't use the standard tests for these individuals, right? And there's even some testing now that can be done in people who are nonverbal, which is terrific. So, and the only way we came to those outcome measures was through a trial and error and watching how sensitive they are to early changes in learning and memory that might reflect dementia, looking to see how they change over time, where are our floor and ceiling effects, and what potentially could move in response to a treatment. And so there's been a lot of adding things, culling things, adding things, and empirically determining, is it moving up with age, moving up with dementia diagnosis. And some of those measures we do are not direct. They're informant-based measures, which, as it turns out, are pretty good. So, and then more recently, there's been more of a discussion of a global clinical impression, I hope I'm saying that correctly, change that's being advocated for in our study that would be fabulous for clinical trial outcomes, right? So it's really come a long way. The diagnosis of dementia for people with Down syndrome, at least in our study, is a consensus diagnosis. That a group comes together, we discuss all the pieces, and then we say that person has mild cognitive impairment or early dementia. So I think that's kind of a little bit of the history of how we got to where we are for these neuropsych test outcomes.
I'm also curious, from your perspective, how much of a challenge is it to understand from this patient population what is from their Down syndrome, where it's coming from their Down syndrome, and where it might be coming from dementia? How difficult is that, and how do we kind of parse through that a little bit?
I think that's a really good question. And it's interesting because when you go into younger ages of people with Down syndrome, say in their 20s and 30s, you're right, there could be some neurodevelopmental features that are explaining some of what we're seeing. And at certain ages for people with Down syndrome, there's a different kind of problem that may come up called Down syndrome regression disorder, which sometimes is misdiagnosed as dementia, but it occurs in much younger individuals, so we know it's not related to AD pathology. So you can't necessarily tease them out, but it makes it for a really interesting kind of thought process, and that is if people with Down syndrome have a different, say, brain structure, then they might have less ability to compensate for some pathology. Does that tell us why they're developing this, why they develop dementia much younger as well, in addition to that genetic driver, obviously. So it's really doubly, triply interesting, and pardon the pun on triple, but there's so many genes on chromosome 21 being triplicated, we don't know what they're all contributing to the phenotype. It's not a simple amyloid precursor protein gene story for people with Down syndrome. There's lots of genes on there. So it makes it really interesting, and I think it's not clear-cut that we can clearly separate the neurodevelopmental piece from the Alzheimer's disease piece.